Hello, everyone. It is truly an honor to be invited to speak at this international conference. This is my first time, and I'm truly enjoying these sessions. So thank you for the invitation. I would especially like to thank my dear colleague and friend, Dr. Jyoti Bajpai, who's been a wonderful collaborator and a tireless advocate for patients with sarcoma and other rare cancers. These are my disclosures. So today I will be speaking about state-of-the-art treatments in chemo-resistant sarcomas. To begin, we must first define what is meant as chemo-resistant. I would say that chemotherapy-sensitive sarcomas have deep and durable responses. They improve progression-free survival, as well as overall survival and quality of life. And anything that does not do this in a meaningful way, it's not just a p-value, would be defined as chemo-resistant sarcomas. Applying this definition, I would say that most of the childhood sarcomas, Ewing sarcoma, osteosarcoma, rhabdomyosarcoma, and few other translocation-associated sarcomas, such as synovial sarcomas and myxoid liposarcomas, are truly chemotherapy-sensitive sarcomas. But the vast majority of sarcomas can be considered as chemotherapy resistant or having intermediate sensitivities to chemotherapies. As you can see in this schematic, Ewing's and PNETs are on the far left-hand side, and something like epithelioid hemangioendothelioma or clear cell sarcoma is in the far right in the highly resistant corner. So from the 1970s onwards, many of the studies that have been done in our field, especially in adult patients with sarcoma, have enrolled all comers, basically any sarcoma histology, regardless of natural history or biology of this disease. With this in mind, let's evaluate a few pivotal studies in the field of sarcoma, which still remain as the basis of the current standard of care. So I want to first begin by talking about the studies that define what is standard of care before moving on to what would be state-of-the-art or even newly approved, FDA-approved drugs. So as you can see here, doxorubicin, which was first developed and shown activity in the 1970s, continues to remain an active drug in sarcomas. Here we see a small single-arm study with responses of 24%, which led to FDA approval of doxorubicin in 1974. In this phase 3 study, Ian Judson at Royal Marsden showed that doxorubicin and ifosfamide have better response rates, they have higher PFS, but the overall survival of the combination is only marginally better than single-agent doxorubicin. And it's also important for us to recognize that the combination of doxorubicin and ifosfamide has much higher toxicities than single-agent doxorubicin itself. Therefore, the combination aim is really used only in patients for whom a response is necessary or who are symptomatic. So Bob Mackey, who was my mentor here at Memorial, first showed the activity of gemcitabine and docetaxel in sarcomas. And here you see a progression-free survival median of 6.2 months and an impressive overall survival of 18 months over single-agent gemcitabine. And this still remains a cornerstone of therapies in sarcomas. In the GEDIS phase 3 study, we saw that gemcitabine and docetaxel compared to doxorubicin are equivalent in all key endpoints, response rates, PFS, as well as overall survival, with the notable exception of quality of life. Interestingly, doxorubicin was much better tolerated and had better quality of life than gemcitabine and docetaxel. In this phase 3 study by Professor Jean-Yves Blay and others showed that in select translocation-associated sarcomas, doxorubicin had higher response rates than trabectedin, but interestingly, this did not translate to improvement in progression-free survival or overall survival. As drug development evolves, we start to recognize that we should be doing more histology-specific trials, and that's how our field evolves as well. So here, Dr. Dimitri and others at Harvard showed in this phase 3 study, which is a global international study, that trabectedin had a progression-free survival of 4.2 months compared to dacarbazine in liposarcomas and leiomyosarcomas. So this is the first study where not all comers were included, but restricted to liposarcoma and leiomyosarcoma. But what's interesting is that there was no improvement in the overall survival. I just want to point out to everyone that liposarcoma and leiomyosarcoma are two of the most common sarcomas. Besides this fact, there's absolutely nothing in common, whether it's natural history or molecular biology, that unites these two diseases. So next we move on to a large study by Patrick Shofsky from Leuven, again in liposarcomas and leiomyosarcomas, interestingly showing no improvement in progression-free survival, but a significant improvement in overall survival. This was only seen in liposarcoma, and the FDA, therefore, label is limited to this disease only to liposarcomas. Here, Robin Jones at Royal Marsden showed that liposarcoma is really 4 different distinct diseases. And the response rate to single-agent doxorubicin is widely dependent on what exact type of liposarcoma the patient is diagnosed with. For example, here you see myxoid liposarcoma has a response rate of 48% to doxorubicin, while dedifferentiated liposarcomas have a 0% response rate to doxorubicin. This is very, very important data for us to understand. When you go back and look at the forest plots in the phase 3 trabectedin study compared to dacarbazine, what you notice is that with dacarbazine is that much of the benefit is driven by the myxoid and pleomorphic liposarcomas. And in fact, there's very little benefit in dedifferentiated liposarcoma. Again, when you go back and look at the subset histologies of eribulin, we again see that the predominant benefit is in pleomorphic liposarcomas. So in this summary slide, if we were to just focus on dedifferentiated liposarcomas alone, we see that the response rate to single-agent doxorubicin is in single digits, and the median progression-free survival is low as 1.5 months, while higher PFS is seen only in the combination studies. So the reason I put this up is to show that even though there are 3 drugs approved by the FDA for liposarcoma alone, that the devil's really in the detail. That when you just look at dedifferentiated liposarcoma, which is the most common subtype of liposarcomas, the efficacy of most of the drugs we use is quite modest, to put it very generously. Again, we clearly see here that with a median PFS of 2 months with trabectedin or 2.2 months with eribulin, I'm sorry, I reversed that, we really need to come up with better drugs. As you can see here, the sarcoma field has been slowly evolving from including all sarcomas to a more disease-specific approach. In this pivotal global phase 3 study, just in dedifferentiated liposarcomas, we enrolled 285 patients. This is the largest study with just dediff liposarcoma alone, who are treated with placebo or with selinexor, which is an XPO1 inhibitor, which is currently approved in myeloma as well as DLBCL. What we see here is that selinexor has a median progression-free survival of 2.8 months in a third-line setting, but placebo has a PFS of 2 months. So although this phase 3 met its primary endpoint, selinexor would not be considered meaningful for most dedifferentiated liposarcoma patients, except perhaps in a small subset of patients as seen by the long tail. The lesson here is that we do not only have to pick the specific disease, but we also have to pick the biologically the right drug and the right target in the disease. So Samsinger, Memorial Sloan Kettering, and others have shown that CDK4 and MDM2 are uniformly amplified in dedifferentiated liposarcoma and could be favorable therapeutic targets. My colleague Mark Dixon at Memorial did these proof of concept studies with palbociclib and abemaciclib in dedifferentiated liposarcoma to target the CDK4 amplification. And what we see here, both single-arm studies, is that the median progression-free survival is now anywhere from 18 to 30 weeks, significantly better than what we are seeing with trabectedin, eribulin, or doxorubicin. Another key gene, as I mentioned before, is MDM2, which is 100% amplified in all the dedifferentiated liposarcomas. And again, we have preclinical studies to show that inhibition of MDM2 could be a potential target in D-diff liposarcoma. So in this proof of concept phase 1 study, we showed that milademetan, which is a very potent MDM2 inhibitor, significantly prolongs the median progression-free survival to 7.4 months. Again, this is a significant improvement over currently approved drugs. But what's important is truly phase 3 pivotal studies to show the benefit of these drugs. So both CDK4, abemaciclib, and milademetan are currently being evaluated in phase 3 global pivotal studies, which should enroll and complete by this or early next year. Next, I'll move on to some recently approved, FDA-approved drugs. Malignant perivascular epithelioid cell tumors, or PEComas, are very rare, ultra-rare tumors which have an intermediate sensitivity to chemotherapies. But we also know that the vast majority of them harbor truncating mutations in TSC1 and TSC2, and thus constitutively activate mTOR signaling. In this pivotal phase 2 study led by Andy Wagner at Harvard, along with Mark Dixon at Memorial, albumin-bound sirolimus has a high and durable response rate of 39%, and this led to FDA approval of nab-sirolimus just about 2 months ago. We next move on to epigenetic targeting, and specifically epithelioid sarcomas. These tumors are defined by loss of SMARCB1 or INI1, and this loss leads to chromatin dysregulation and oncogenic upregulation of EZH2, which is an oncogene, which is part of the polycomb repressive complex. So in this global phase 2 study of tazemetostat, which is the EZH2 inhibitor, we showed a 15% response rate that were prolonged and durable for these patients. And this led to the FDA approval of tazemetostat in advanced epithelioid sarcomas. We used to consider epithelioid tumors as resistant to chemotherapy, but in these 2 large multi-center retrospective studies, we showed, along with Dr. Stacchiotti, that epithelioid sarcomas, especially the rapidly dividing and symptomatic ones, do in fact respond to chemotherapy, but these responses may not be durable. Next, I'll move on to tenosynovial giant cell tumors. These are truly chemotherapy resistant diseases which we never use chemotherapy. These tumors are defined by overexpression of CSF1 or stem cell factor 1. In this phase 3 study led by Bill Tapp at Memorial, nearly all tumors responded to pexidartinib with excellent improvement in quality of life. This again led to an FDA approval in this indication, but it does have a black box warning to monitor for liver dysfunction. In this study, we did next generation sequencing of close to 7,500 sarcomas. And what we showed was 3% of all sarcomas harbor kinase fusions that are targetable by current drugs, many of them approved or some in clinical trials. Particularly are ALK as well as NTRK fusions, and ALK particularly in inflammatory myofibroblastic sarcomas. So here's a patient of mine with advanced sarcoma, MPNST, harboring a NTRK fusion. who had a complete response to larotrectinib and is now 5 years out and still remains on the drug. So this patient of mine enrolled in this pivotal study led by Alex Drillin and David Hyman, which then led to a pan-cancer approval of larotrectinib in tumors that harbor NTRK gene fusions. Next, I will shift gears and discuss receptor tyrosine kinase in sarcomas. So almost 10 years ago, this pivotal phase 3 study was published by Winnet van den Graaf of pazopanib, a multi-targeted kinase, which showed an improvement in PFS of 4.6 months over placebo of 1.6 months. And this was approved in soft tissue sarcomas, but not in bone sarcomas. But this also is important to know that this did not show any improvement in overall survival. Also important to note is that the response rate with pazopanib in this pivotal study was very low, less than 5%. So the Spanish, Italian, and the French Sarcoma Consortium led this phase 2 study of pazopanib in solitary fibrous tumors, which are generally of intermediate sensitivity to chemotherapies. Here in this particular subtype, we see an impressive response rate of 58% and a median progression-free survival of 6 months. Again, we see the role of several receptor tyrosine kinase inhibitors in refractory osteosarcoma. Here, Lara Davis at Oregon and Bob Mackey at UPenn showed a 13% response rate with regorafenib over placebo. There are clearly a subset of patients in osteosarcoma who do benefit with TKIs, but the biomarkers are not clear and under current investigation. Colleagues in Europe just published an interesting efficacy and safety data combining lenvatinib and ifosfamide and etoposide. Prospective randomized studies are currently ongoing in this space. Lastly, to round out the receptor tyrosine kinase story, desmoid tumors, which are generally sensitive to cytotoxic chemotherapies, have a high degree of overall response rates to sorafenib, and the French showed also to pazopanib as well. But in this phase 3 pivotal study, we showed a 7-fold improvement in PFS over placebo with a hazard ratio of 0.12. In the United States and in some other parts of the globe, sorafenib is now increasingly used as a first-line drug to treat desmoid tumors over even chemotherapies. Another chemorefractory disease is clear cell sarcoma, which has a high MET expression. Here in this study led by Patrick Shopsky, we see a very low response rate, but some disease stability. Clearly, more work needs to be done in this space. Generally, angiosarcomas are chemotherapy-sensitive cancers, especially to microtubule inhibitors such as Taxol and docetaxel, as well as doxorubicin. However, neuropathy can be very problematic, especially in older people. Oraxol is a new formulation of Taxol with a high bioavailability and has shown very high response rates and, surprisingly, a very low neuropathy and very well tolerated. And this study was led by my colleague Vinod Ravi at MD Anderson. So what about immunotherapies in sarcoma? Interestingly, immunotherapy may be effective in select chemoresistant sarcomas such as UPS and liposarcoma. Here, colleagues from MD Anderson, Hussein Taubi, and others showed that pembrolizumab single agent has a 20% response rate, especially in genomically complex sarcomas such as undifferentiated pleomorphic sarcoma. My colleague Sandra D'Angelo at Memorial conducted this randomized study with nivolumab versus nivolumab plus ipilimumab, and again showed that response rates with combination of checkpoint blockade is effective in undifferentiated pleomorphic sarcoma as well as genomically complex sarcomas. Here is a very interesting study done by Breland Wilkie at University of Colorado that showed durable responses in alveolar soft part sarcomas with a combination of axitinib and pembrolizumab. ASPS is a very chemo-resistant sarcoma, and we don't fully understand what is the mechanism of action of these drugs in this disease. Lastly, this is a very interesting study evaluating death receptor 5 agonist antibody in chondrosarcoma, where several partial responses and durable stable disease was seen in this typically highly chemorefractory disease. Here you're seeing two very impressive responses on the study. Currently, a pivotal study that is randomized between INBRX 109 versus placebo is currently ongoing. Next, we move on from checkpoint blockade to engineered T-cell receptor therapies. So Seth Pollack at Northwestern showed that both synovial sarcoma and myxoid liposarcoma express high levels of NY-ESO1 and MAGE4, two cell surface proteins. By genetically engineering a high-affinity TCR, T-cells are programmed to attack these sarcomas. However, they are limited to patients who express HLA-A2. So in this phase 2 study, Sandro D'Angelo showed impressive responses in myxoid liposarcoma. As you can see here, a patient with a huge thoracic mass that responds by 3 months. And again, here we see response in synovial sarcoma targeting MAGE4 T-cell receptors. Again, showing a 40% response is truly impressive in synovial sarcoma that is refractory to standard chemotherapy. Lastly, my colleague Kira Kelly is leading this program with pembrolizumab and intratumoral injection of TVEC. This is a drug that is approved in melanomas. You can see this, both of them patients of mine, who one of them facing an amputation, who had a near CR to this and essentially cured of her undifferentiated pleomorphic sarcoma. Further studies evaluating this combination are currently ongoing. What I want to finish off is with this very large next generation sequencing study that we did, which essentially showed that the use of molecular diagnostics, especially next generation sequencing, changed the pathology diagnosis in about 11% of our patients. So on the left-hand side are the pathology that was originally made, and on the right-hand side are the new confirmed pathologies. So what I would like to conclude with is essentially don't overestimate the role of cytotoxic chemotherapies. Don't underestimate the role of cytotoxic chemotherapies, even in these so-called chemo-resistant sarcomas. Histology matters greatly, and so we must pay attention to whether the histology of interest was truly enrolled in the study. Always make sure the pathology is accurate. Molecular diagnostics is key. Getting a second opinion from a sarcoma pathologist is key. And finally, always discuss your patient in a tumor board. Thank you for your attention.
Very much, Mrinal. Indeed, it was great. And I'll again ask Dr. Bivas to take few questions.
Thank you, madam. And it's good to see Dr. Mrinal. Very good. Happy New Year to you. So it was a very exhaustive and very exciting actually topic discussed that cover almost all types of sarcoma in resistant setting, refractory setting. And I feel the outcomes look brighter in as per the soft tissue sarcoma treatment is concerned. Too much of development is happening and too much of study is ongoing, and that too with a very promising study in few of the area. So I'll ask Mrinal few of the questions or queries that you can put your insight or enlighten us about this. We do face challenge in diagnosing these sarcomas, especially the rare subgroup. So we do have a logistic issue to using broad molecular panel. So do we use broad molecular panel, including the NGS, for all your sarcomas upfront, or do we do it in a resistant setting?
Yeah. Good evening, Bivas. Nice to see you. Nice to see Dr. Stakiadi and Jyoti and Dr. Kasali, and I think Dr. Gronki is coming next. It seems like we're at a little cafe, just the 6 or 7 of us having coffee or something. Yeah. So to answer your question, when should one use next generation sequencing? I think whenever, if you're not sure what the diagnosis is, I think it's a reasonable time to ask. I think the first order of business is to ask a person who has a lot of experience with sarcoma pathology to just look under the microscope in the right clinical setting to say, what do you think this is? And if they are scratching their head and they do some molecular testing and it still is unrevealing, it may be at that point much more cost effective to spend the money on next generation sequencing and get the right diagnosis, because that's the foundation of everything. Of course, these tests are expensive, but I think just as anything else, the cost of technology is rapidly dropping. And, I think the question is, if you take cost out and if you just said, what if it costs, $50 to do it? Would we still have a debate about it? And I think the answer is probably no. I think the main reason we're still talking about whether we should do it or not is primarily related to, the cost associated with this. So when should you do it? I think the simple answer is if you're unclear about the pathology, one should do it. But here's the thing, right? What we noticed is in the 11% of the diagnostic errors that we saw, a lot of these were not rare or ultra rare diseases. These were sometimes pretty common ones. For example, a good number of patients, say with Ewing sarcoma, it was not picked up. People are just calling it a soft tissue, and some regular soft tissue sarcoma, so-called soft tissue sarcoma, turned out to be Ewing. I mean, that has a huge implication on overall survival. And obviously, it also has an implication on patients receiving unnecessary chemotherapy, Ewing-like regimens for a year or so. So I think, fundamentally, I can't tell you which is where you should do or not do. I mean, for example, I never do NGS in desmoid tumors, for example. And so, yeah.
Thank you.
By the way, if you notice in the desmoid slide that I had, one of your patients' pictures was actually on it.
Yes,
and this is a patient we shared many, many years ago. I hope she's doing well.
She's doing well on sorafenib, almost 3.5 years now.
Yeah.
So follow up to that question, what is beyond sorafenib in desmoid? What do you see?
Yeah, so there's a lot of, I think one thing with sorafenib is that it's a toxic drug to take for a prolonged period of time. Just as pazopanib or really any TKIs. I think many of these drugs you can take for 2 months, 3 months, 4 months. But when you have to take it for 8 months, 10 months, 15 months, and you're a young person and you're having you have to live a normal quality of life, these drugs are tough from a chronic situation. The new or the hottest drug is this gamma secretase inhibitor, which we are all eagerly waiting to see what the phase 3 study will show. But at least looking at the phase 2 data and the phase 1 data, the side effect profile appears to be much better tolerated than sorafenib. So, we're all eagerly awaiting for the data to come. This is also an oral drug. So I'm hopefully this is a way forward in terms of good efficacy, but more importantly, much better tolerability in the long run.
Safety profile. Yeah. Thank you. Yeah. So one question on different liposarcoma. We have used 2-3 patients on palbociclib. We did see long-term disease control, but these are all unselected cases. So we do not have CDK4 amplification probe. So do you recommend to use this CDK4 inhibitor only for amplified tumor? And where do you place palbociclib? In which line?
Yeah. So you don't really need to, if you're sure that this is dedifferentiated liposarcoma, you don't need to do NGS sequencing. Close to 98, 99% of them will all have CDK4 amplifications. In very rare situations, the CDK4 is not amplified. Instead, cyclin E is amplified. In even rarer situations, you can find mutations in retinoblastoma gene. In that ultra rare situation, the palbociclib will not work. But otherwise, if you have a dedifferentiated liposarcoma and you're sure about the diagnosis, even with IHC, you can go ahead and treat with palbociclib. When should you do palbociclib and when should you do chemotherapy? I think the general rule of thumb is if the disease is very rapidly growing, then do chemotherapy and then switch over to palbociclib once you have some disease control. But if the disease is slowly progressing, I think you can easily go to palbociclib. In fact, Mark Dixon, who's running the phase 3 study with palbociclib versus placebo, it's actually you can enroll patients in the first line setting. And the rationale is none of the drugs that are approved, doxorubicin, trabectedin, eribulin, none of them have shown improvement in overall survival. And all the benefits have been marginal. So we can't make the argument that, oh, we are robbing the patient of some life-saving drug. That's not the case at all.
Yeah, thank you.